You don't want to sit in the middle?
Okay, we're going to get started. Hi everyone, my name is Hayley. I'm the program coordinator for Democratizing Knowledge. Welcome, thank you all for being here. It's lovely to see so many faces and also some familiar faces. I just want to give thanks to Onondaga, on whose territory we're meeting today, both to the land and to the ancestors and to the current people of this place. I want to make a couple of quick announcements. These are for events that we have coming up. So if you will just bear with me before I introduce our speakers. The first is a film called 3,000 Nights. We are also being visited by the filmmaker, Maya Masri, 7 p.m. Wednesday, April 18th, 2018, in Shemin Auditorium in the Schaefer Art Building. Okay, really important film that deals with, amongst other things, Palestinian struggle for freedom. And the second event I want to make sure that I reference is another film called Asmarina. That film will be showing Monday, April 23rd, 5 p.m. in Watson Theatre. We're also really privileged to be joined by Medine Paulus, who is the filmmaker. And also she's currently visiting at Harvard. And also Lorgia will be here. I'm just trying to remember. Garcia Pena. And her book on Dominica has just been awarded the NWSA book prize.
Gloria Anzaldúa.
Yeah, Gloria Anzaldúa prize. Thank you, Chandra. So we're really lucky to be having her come and visit us at this time as well. It's a really timely visit for both of those reasons. So please come and engage in conversation with those filmmakers and with the films. And now, I'm so excited to be able to welcome our guests. I'm going to do a really quick introduction and then I'm going to turn it over to them so that we can spend our time this evening listening to what they need and will be sharing. So let me just do a quick introduction. We are joined by three esteemed reproductive justice and birth workers. So we have to the far end, Sequoia Kemp, who, as well as being a Black Lives Matter activist, I was just saying to Sister Estia what an accomplished young woman she is. So, yes. Black Lives Matter activist. I did a little bit of snooping, you see, Sequoia, to find out what you've been up to. She has a business, I know, called Doula for a Queen. She was trained to be a doula through Syracuse Healthy Start. And she also has a bachelor's in health, behaviour and society from the University of Rochester. She is joined by Estia Bay in the Siena. Estia is a registered nurse, a certified lactation consultant, founder of Co-Mothering Central New York, a Village Birth International partner, a community doula trainer and a mentor. So I want to talk a little bit about Village Birth International. So Village Birth International advocates for respectful maternity care. It was founded in 2006 and it engages maternal health models that work for families and carry a wide-reaching impact on communities. In Syracuse, Village Birth International's work with women of colour, refugees and LGBTQ families also engages the ways systemic racism, national identity and economic conditions affect birth outcomes, maternal and family well-being. So thank you both for being here. And I want to welcome back Dr. Griselda Rodriguez-Solomon, who describes herself as a mother, a birth justice advocate, a professor at the City College of New York, and a kundalini yogi. Griselda is also a graduate of Syracuse University, 2010, 2010, with a PhD in sociology, who headers Myths and Margins, the capitalist world economy and its implications for Afro-Dominican women. Wow. She did that. And she's a past graduate assistant of Democratizing Knowledge. Yeah. She was, in fact, the first graduate assistant and worked with Professor Kali and Professor Mohanty to establish this program. Thank you. So it's so exciting to have you back. And I want to just add a couple more things about Griselda. She was trained under Ancient Song Doula Services. Her praxis is grounded in advocacy around the rights of women of colour during and after birth. She's authored a chapter in the anthology Birthing Justice, Black Women, Pregnancy and Childbirth. And close to my heart here, the home birth of her son, Talib, she describes as having transformed her life. So thank you for the three of you. As you know, we are leaving this to you in terms of how you want to share your knowledge and how you also want to interact. And there'll be time for us also to interact and be a part of this conversation. So I'm leaving it over to you. Thank you so much.
Thank you all. Got it.
Yeah.
So hi
The
everyone.
doctor goes first.
Good evening, everyone. Good evening. Thank you, Haley. Thank you for inviting me. Thank you, Democratizing Knowledge. It's surreal to be back after almost 10 years. Just walking through the campus, it's amazing how much I've grown, how much I've changed. And in 2010, when I graduated, if somebody would have told me that I would be coming back to speak on a panel about birthing justice, I'd be like, what? But, you know, I was open to the course that the Creator had for me. And a lot of people, I'm sure that the doulas in the room and the birth workers, first of all, who knew what a doula was before today? Who did not? Okay, so I'm in a room of peers. But a lot of times people look at the word and they're like, what the hell is a doula? What is that? So it's a birth worker, it's a birth assistant, it's a birth advocate. Traditionally, women gave birth with other women in attendance, usually the person's mother and grandmother and sisters. For those that are from other countries outside of the US, it may still be the practice, or if you're older, you may have familiarity with that practice. But because of capitalism and the shift in economies, a lot of people don't have the privilege to live around family members. So doulas kind of step in to take the place of that proverbial village that is so essential for birth. And the job description of a doula is that we provide emotional and physical support during and after labor. But doulas of color, we understand that our role goes way beyond that, right? You become a social worker, you become a cultural broker, you become a therapist. You kind of take the place of a lot of the services and support that the family often needs but lacks. Another thing that I'm sure doulas are often asked personally is why or how did you become a doula? In that book chapter that I authored a few years ago, I tell the story of my trajectory as a doula, and it started when I was 8 years old. And I'm Dominican, and I'm a first generation, meaning I was born and raised in the US, the first in my family. And my cousin was in labor, and she didn't speak English. And my godmother called me into the apartment. We lived next door, and I was 8 years old. And my cousin was in labor. And because of, I always reflect on how within a patriarchal society, women are traditionally expected to be contained. You don't take up a lot of space. You can't speak loud. You're not allowed to have big personalities, especially black women. So to see my cousin on this bed, like squirming and making noises that I had never heard a woman make, especially coming from a Catholic background, that left some imprint in my psyche that I think years later, when I saw The Business of Being Born, who's seen that documentary? Oh, please watch it. It's on Netflix. People consider it to be a shockumentary, but it's a documentary about the commodification of birth and how it's so profitable to transform birth into a money-making venture as opposed to letting a woman or a person do what they need to do to have birth. So I saw that documentary and all these memories started to come up, and it was my training here. I mean, I have two of my mentors here, Linda Cardi and Chandra Mahanti, that I think really shaped my perception of birth, because I understood that I wanted to be present while women are giving birth, not only because it was something that came out of my heart, but I understood it was a necessity. So throughout the night, you're gonna, hear a little bit more about our respective stories, but also the necessity that, the very necessary role that we play because of the racial disparities in maternal health. I mean, the U.S. has one of the worst maternal mortality rates in the developed world, which is shameful, but we spend the most on maternal health. So that contradiction is something that as a scholar, I'm trying to understand. How do we spend so much on birth, but our women are dying at high rates, especially Black women.
Thank you. I just want to say, too, that I'm really honored to be here. It's so interesting, actually, to be at Syracuse University talking about reproductive justice, because a lot of times it is, you guys are way up here, and the women that we see, this is another world to them. And so to be able to have this experience to share their stories with you it feels pretty good, just to say that. And we have some doulas in the room, and I also wanted to say that Sequoia was trained by Village Birth, not Syracuse Healthy Start. So, I think locally, when we think about all of the things that Griselda was just talking about, we see that as a crisis. Women who live down the hill, they are living in crisis every day. And so when we think about reproductive justice and birth, we're not just talking about the day that they go to the hospital and have the baby. Birth workers are really, they're kind of like a throwback to that ancestral piece of sisterhood. And so that's where co-mothering came from. Mm-hmm. It really is not so much about people coming together, but women and birthing people come together to support one another in all kinds of trauma. And that's how communities heal. There's therapists and all those things, but really when you have a collective community standing with someone in a time where they need support, that's the answer to infant and maternal mortality. Somebody showing up who looks like you, who understands the trauma that you have had or no trauma or whatever that is, and supporting you through the most precious time in your life. That is a healing circle. And so that's what we're trying to cultivate in Syracuse. It's a small collective, but we are a group of powerful women who really believe in the healing power of community cultural competence, basically. And so Syracuse is just like most other urban cities. There's not a lot of money. A lot of women don't have access to good health care. If you have Medicaid, there's only basically 2 clinics that you can go to. A lot of those people that are there, they don't look like them. We have so many refugees who don't speak English. We have so many competent but also incompetent people reaching out to them, trying to help. It's a cultural divide. So why not empower women from those communities, from those countries, to be advocates? And birth is the first place to start. So I just want to say that, that's reproductive justice. And today I wore my shirt when I think about all of the people who were killed by gun violence or some kind of violence, because we need to start connecting birth work and infant mortality, reproductive justice, to not having access to good education. We need to start connecting it to living in gun violence in our neighborhoods. All of those things affect a woman or a birthing person as they go to the hospital to have that baby. So that is reproductive justice, and that is all of those other justices that Sequoia fights for on the daily. So I just think that we need to have a robust conversation, first of all, about how culturally people can heal each other as in circles of birth workers, and also about how this is connected to gun violence and prison to pipeline and all of those isolated justice movements. Reproductive justice, it should be the driver, and many times people aren't talking about what that means. You want to use my microphone?
So everything they said is just spot on. How I came into birth work, I was 14 years old when I first attended 13 when I first attended my first birth. My mother on the front row didn't want me to let me to go, but I cried because I wanted to be there for my family friend member. And it wasn't until I was in undergrad where I changed my major to public health because I met with a midwife, and I was saying, I care about all these social aspects of birth, and if you don't have money, how can you afford the things to take care of your child? If you don't have a car, how can you get to your appointments? There's a lot of different aspects that go into healthcare that a lot of people don't think about, and a lot of times women are blamed. Well, you're blamed for not going to prenatal appointments. It was there's a lot of barriers that stop women from going. So for me, it's about validating the experiences of birthing people, and also recognizing the determinants that produce these outcomes that we have. And for me, when I was an undergrad, I was in it was the intro course, and every topic we talked about, it was like Black people were the highest risk to die. Black people are the highest risk for this. Like no matter how much money or education we have, Black women still have the worst health and maternal outcomes compared to our counterparts. So I can be making $60,000 and my white counterpart can be making $60,000. I can still have access to the same health care that she has and still have a worse maternal outcome. So it goes beyond the healthcare system, but it's what about society is producing these type of outcomes. And for me, it was that racism really is deadly. And that was like something that just woke me up in college, because I'm like, racism has to be it. Like if we go into a doctor's appointment and we feel as though our doctor is looking at us a certain way, or they have preconceived notions, how do we feel open to let them know that these are the type of concerns we're having? If we're saying, I have clients who have said, like, I felt pain and it was oh, it's not that big of a deal, and then it ended up being a very important medical condition. So there's a lot of different socio things that impact birth. And for me, we watched this documentary called Death by Delivery. If you haven't seen that, also you should watch that. It's on Fusion, I believe. And we were learning about how Black women in New York State are 12 times higher, have 12 times higher chance of dying after giving birth from birth-related reasons. And one of the doulas in the documentary said that her role, she felt, was like, Black doulas is a sisterhood, and our role is to break this cycle of traumatic birth, and that birth doesn't have to be traumatic, but it is, and recognizing why is that, and using our collective power to address those circumstances.
So I was sitting here thinking, I don't know if Cardi, if you remember, so I majored in sociology, but I spent my thesis advisor, the dissertation advisor, Linda Cardi, was in African American Studies, and African American Studies started a Pan-African Studies master's program like my third year here, so I flocked to them because it was a source of solace. And I remember one day Cardi telling me that the building in which African American Studies is housed is named after the so-called father of gynecology, Sims. And I don't know, I remember that moment, we were in your office and I was like, okay, I was probably like 23, 24, and starting to make sense of how white supremacy and racism work, that it's not like we're told that we're inferior, it's symbolically how these things like are like ingrained in our psyches. So that kind of like another thing that was etched in my psyche. And then years later, I come to learn that this man was responsible for performing atrocious experiments on enslaved African women without anesthesia. So the gut-wrenching or womb-wrenching reality is that a lot of the things that women benefit from, or people with wombs benefit from, were developed on the backs of African women in this country. And to know that that man's name is etched in the building where, African American Studies is housed, it was just too ironic, right?
Yeah.
And now women and gender studies.
Really? Oh, and now women in gender studies.
We have the honor too.
Right? It takes me back to like the Confederate statues in the South that, sisters like, I'm losing, what's the sister's name that, well, she climbed the flagpole.
Yeah.
What's her name?
Is it
Brittany.
Brittany, she climbed the flagpole and ripped the Confederate flag down, but it's these symbols that really sustain this structure that keeps people on the margins, those that are not part of like what Audre Lorde calls the mythical norm. And I want to talk a little bit about birth justice, because a lot of times people assume that birth justice and reproductive justice are the same thing. And there are a lot of similarities, and birth justice is birthed out of the reproductive justice movement. But it was necessary, especially like in the late 70s, 80s, because middle-class white feminists at the time, and there's benefits to that because a lot of people who have benefit from those struggles, we're very big on like a choice. We want choices. We want choices. We want to have the choice to have an abortion and to have safe abortions and not die. And that was especially pertinent for women of color because we were dying at very high rates from illegal and unsafe abortions. But then a lot of women of color started asking, but what happens to people that want to have babies? What happens to people that want to have babies and want to conceive a child, carry a child, birth a child, and most importantly, going back to this idea of gun violence, and raise children in safe environments, especially black children, especially black male children. You know, and this is where Sister Song is a collective that was birthed out of that, where black women gathered and they're like, we want to be able to have the choice to have an abortion or not. And if we have chosen to have a child, to be able to carry that child, birth the child, and raise the child in a humane way. You know, I teach gender studies at City College, and a lot of times my students are often taken aback at first when I challenge them to think about this notion of choice as being very limited, right? Because not everybody has the same access to resources to be able to have the right to choose in the same way. So birth justice is a momentum, it's a movement that people are proclaiming the right for people with wombs, women in particular, to have children in a humane way. I have been a doula for 6 years now, and the doulas and midwives and other nurses, doctors in the house that have spent hours or days on a labor and delivery floor, you get to see how inhumane it is. And I used to get really upset and really come down on the staff and the nurses and the doctors, but the nurses a lot of times are mostly women of color, immigrant women of color. They are overworked and underpaid, and they don't have the time to be able to dedicate 100% of their energy to ensuring that this person that just walked in the door is gonna have an empowering birth, and that's where doulas come in. But it's gut-wrenching to see that the people that are responsible for ushering in new humans for our society to thrive are so spent within this machine that they don't have the capacity to offer these families the type of support that they need. That's why myself and a lot of other people consciously chose to have birth at home. Home birth, it's not something that I advocate for everybody, but I do say that if you are thinking about having a child or you know someone, if you are low risk, to consider having a home birth. I ended up having a home birth without telling a lot of my family and friends because a lot of fear was projected onto me, right? Because we live in a culture where allopathic medicine is risen to this level that is godlike. And if you so-called defy allopathic doctors or go against the stream and go to see a naturopath or go to see like a healer of sorts, a spiritual healer, you're considered crazy or putting yourself and your child at risk. But I knew as a doula at the time, I gave birth in 2014, so that was 2 years after I had trained as a doula, that I did not want to put myself in that position where I was going to be exploited, where I was going to have to be forced to give birth on my back, where my right to choose the type of service that I wanted was compromised because the minute the staff walks in the door and see this brown skin and curly hair and my accented English, there's going to be a lot of assumptions about who I am and the type of service that I'm going to receive. You know, and we could sit here and we can divulge on all the statistics, the heart-wrenching statistics, but I'm sure that you all, I have a feeling that almost everybody or everybody in this room is here because they care about this topic or just social justice in general. I just feel like as an advocate, as a professor, as a mother, as a doula, I don't understand how birth justice is not on the forefront of so many movements.
Right.
Because we're talking about the human beings that are going to be leading our world 10, 20, 30 years from now. There is, I just recently learned about epigenetics. So it's this school of medicine where, who has heard of epigenetics? Right? A lot of people know it, but I knew of it, but I didn't know the term because of alcoholism. There's been recent studies in the last 2 or 3 decades that alcoholism in essence can be, it's hereditary because your genes start to transform in a way where you can pass that on to your children. But epigenetics is also about how your genes are transformed because of your environment. And there's a lot of work coming out now about epigenetics and racism, right? That when you are exposed, racism, sexism, homophobia, anti-immigrant sentiments, and imagine the intersectionality of those, right? Ableism. When you are constantly being questioned about your sense of self as a human because of the way you look, because of the way you're gendered, because of the way you speak, there's research to show that your genes start to wear down. And this is why, as Sequoia was saying, two women, a black woman and a white woman, when you control for class, right? The black woman will have issues during birth more than likely than her white counterpart because of the genetic, transformation that happens with something called microaggressions, right? Ina May Gaskin, anybody know who that is? Ina May Gaskin is like,
She's like the midwife white guru.
yeah, she's like a older, crunchy granola. I mean, I met Ina May Gaskin, and quite honestly, she's the reason why I chose to have a home birth, because I was 5 months, and I was not sure what I wanted to do, and she was like, "You need to like get out of the birthing center and go." Anyway, she's been under fire in the last 6 months because she was at like a birth collective, a conference, and they asked a question about the racial disparities in birth, and she pathologized black women because of epigenetics to say, well, they're just predisposed to be unhealthier, or if they would just take, I don't know if you have better details.
No, I don't know exactly what the words were, but she said something about our bodies having this predisposition to not be able to birth in ways that were healthy outcomes. Yeah.
In the concept of the environment.
Yeah, yeah.
So this is a woman, she's like the guru of natural birth, and she's in a sense sort of fallen from grace because of the fact that she wasn't able to see this phenomena from a multidimensional perspective. Because I'm with her to a certain extent because of epigenetics. Our bodies as women of African descent are just worn, right? Worn to the point where, like, I have a testimony. I just had a cousin, 57 years old, who passed away 2 Mondays ago from mesothelioma, which is a very rare form of lung cancer, that she has a case pending, may she rest in peace, that the lawyers think she developed because of the asbestos in the boilers of the factory warehouses that she worked in the 90s when she came to the United States. Right? So this is real. Poverty has very real effects on people's bodies. But we have to be careful, because if we don't have a sophisticated lens, we can pathologize those communities even more to say, well, she probably died because she was predisposed to get sick anyway. Not that she was part of a structure where she was forced to stay in those dilapidated warehouses that, ironically, because of gentrification, are now gutted and cleaned, and like hipsters are now living in those same warehouses in Williamsburg that my cousin spent many, many years. Now the family is concerned because now we want to look at how many other people worked in those same factories and getting them tested to see if they've been affected by the same disease.
Yeah. One of the things about stress is that part of the issue is that our bodies have a physiological response to stress. So you know how it feels when you get angry or you get worried. Imagine what that feels like daily. I mean, if I think about the women of color who go to SU and who are going through the PhD program, or who are dealing, and I hear their stories, or I think about my experience in school in a very large white institution, being one of the only one. I'm the only African-American nurse in population health at St. Joe's. There's like 18 different ones, and I work at the West Side Clinic. And it's, if you have these interactions of people not really knowing how to engage and trying to figure it out, your body responds to that. You might not think so, but cortisol is increased. And so that is not good for a pregnant woman. And so we need to start, and there's lots of research now to show how not that our bodies are predisposed, but our environment is actually attacking us. And so our health fails because of it. And so I think it's important to think about that. And I also think that it's so ironic, Ina May Gaskin, that whole thing. She was a midwife in the 1970s. She basically revolutionized natural home birth, right? My great-grandmother and my grandmother were midwives in Texas, and they birthed like hundreds and hundreds of babies post-slavery, and probably they had people before that birthing babies. I remember when I was 5 years old, sitting at her feet and talking to her, and I hear stories of my aunts, and they were like, she never lost a baby. She never lost a baby. So, you know, you have somebody like Ina May Gaskins who like revolutionizes this natural birth movement, but then you have all of these practicing Asiatic women, these African women, descendants of slaves, practicing it for hundreds of years and being forced out through policies of Marion Sims and the state and health department saying that they're not qualified to have this title as a midwife. So it's kind of ironic, but not really. It's kind of surprising, but not really. So, and then I also wanted to just say that there's a movement now to frame what Griselda was talking about as a human rights. It's our human rights are being violated. When we show up to the doctor and people are extending to us in ways that are culturally incompetent, or they're not giving us pain medication, or even somebody like Serena Williams, who didn't quite understand what she experienced at first. She came back and started to place herself in the context of Black and brown infant mortality. But at first, she didn't get it, right? So she had a baby, and after her birth, she started to have these pains, and she has a history of pulmonary embolism. She knew exactly what was happening to her body. She knew it. She went to the nurse's desk and was like, listen, this is not right. I need a D-dimer and a chest x-ray right now. I have a pulmonary embolism. And they were like, what? And she had to keep advocating for herself. And lo and behold, she had a chest x-ray. She had a blood clot in her lungs. I mean, I've seen people who have pulmonary embolism. It is scary. They can die like that. So that to me was unbelievable. But they weren't listening to her. And she wasn't really able to contextualize it around race at first. But I think that the research shows that Black and brown people are not listened to when we show up. And so imagine what that feels like for her. So now she has this experience as a mother, even though she's Serena Williams, and she reflects back on that moment. Like, that is so stressful to me. I can only imagine what she might be feeling. Like, is she going to be trusting again for when she goes back to the doctor? So these are experiences that women are facing all the time. And so to frame that in a human rights, like her human rights were violated, or to frame that in a way that says she did not get access to the best care that she could have at that moment. The state or the health department or whoever in charge of making the legal laws, they violated that. So we need to start thinking about just not women not having access or all of those things, but it's a human rights violation. And I think one of the things that is very important to us, even all the way up here in Syracuse, is that we start to see how nationally birth workers are engaging their communities. And one of the ways is through Sister Song, and also this group called the Black Mamas Matter. It is a powerful group of African American women, and they really started to, they're policymakers, she's a public health person, and they really contextualized this toolkit for communities to really understand what they should be receiving when they show up in healthcare. And they're framing it around human rights violations. And so we are really trying to get people to understand that, even on a very basic community level. I mean, the language is this policy. Nobody understands legislation. But we're really trying to engage the community around that so that when they go to the hospital, they have a platform they feel empowered enough to say, you know what, you're about to give me that episiotomy, but you didn't ask for my consent, so stop right now. Like, we need to have the language to be able to say no, and a lot of people really don't, and that's where suffering comes in. I just think that I think back to my own experience around birth. You know, my husband is from a huge, very religious family, and it was 17 years ago when I had my first child, and I had so many other mothers around me that it's hard for me to even contextualize that people actually birth alone. So many of our people are just having babies independently. And they have family, but for whatever reason, they're not there at the birthing room. They're not there when they're going to the hospital for their appointments. And so they really don't even have any clue that they should be getting more. A lot of our young people are the same way. A lot of refugees, they don't have the language, but they still show up by themselves because their husband's not going or whatever. And so it just makes me, I think it makes me sad to think about all of the women that we're not reaching when we have these conversations.
I'm thinking about so many things. There's like so many things to touch on. What it keeps coming to my mind is about the idea of choice. So in most cases, I'm younger than my clients. And so when I go and meet people, I try to think about, what can I offer to this person who maybe are having their second child. A lot of people ask me, well, how could you know what to do if you've never had kids? And for me, every time I get that text that someone's in labor, I'm like, it's go time. Like, this is the moment in which you change the trajectory of someone's life. I've had clients who didn't know that they can deny being checked, having vaginal checks during their labor. And being a doula for me is being knowledgeable of triggers, being knowledgeable of past traumas, and acknowledging that this is your birthing experience. It's something I always tell my clients, that it's your birthing experience, and we're going to make it what you want to be. And that means navigating through the family. Families are always asking, how many centimeters are you? How many centimeters? And I have to say, just let it happen. Like, you have to use language like, well, let's allow her to rest, or let's allow them to get a moment to breathe, because sometimes that anxiety and that worrisome and that excitement, it causes the birthing person to feel as though they have to get a vaginal check because my family wants to know how many centimeters I am. And being able to recognize that this is your body, and this is an experience that this might be the only experience that you have where you feel you have in control. And I feel a lot of my clients, when they're younger, there's this dichotomy. Well, if you have a kid, if you're 16 and pregnant, you shouldn't be having kids that young. And there's like a lot of stigma that comes with that. But then if you're, they say seasoned, if you're over the age of 35, well, why are you having kids so late? And all of these things that have to go in someone's mind when they're pregnant. So for many people, it could be the happiest time of their lives. And for a lot of people, it's not. So a lot of pregnancies are not planned. So it's being able to keep all those things in mind when you're dealing with someone, making sure that you're being cognizant of the language that you're using so that they feel validated throughout the pregnancy. And also being able to empower, like you said, empower them to be able to say, hey, I'm not comfortable with this. There's so many clients I know who requested that they don't know that they can request different physicians. They don't know they can request different nurses. It's just all the different experiences. I think about how, like, a person is pregnant and they're in labor, going through excruciating pain, and they're people are being rude to them. Like, you think about, how is this impacting your experience? You're already in pain, and then stress intensifies the pain that you're in. So there's so much that I can go on and on. There's so much that goes into the birthing experience that I try to be cognizant of how, the atmosphere of the room, of interacting with the physicians, making sure that they're aware of how if they need medical intervention, how are these medical interventions going to impact their bodies, and being able to empower them to be able to say, this is what I want, this is not what I want, and for their rights and requests to be respected. Because in many cases, I've had people say, well, I didn't know that I could do that. I didn't know that I didn't have to have, if I had an induction, I can request what type of induction I can have. I didn't know that I can birth in a jacuzzi. There's so many different things. So I try to offer this information so that people are reflecting on their birthing experiences and it's not traumatic. And in the documentary that I mentioned earlier, one young woman was saying that they kept pushing a cesarean, and she was like, I don't want to have a C-section. I want to have my child naturally. And she was saying that she doesn't even know what she's going to tell her child when they ask, like, what was it like when you had me? She's like, I don't even want to reflect on that. She was in labor for, 40 hours? Mm-hmm. And for me, that was heartbreaking because I feel as though that is such a pivotal moment. Like, birthing a human being into this world is such a pivotal moment. And for her not to even want to reflect on that, it can impact depression, baby blues, different mental health factors. So for me, it's about recognizing how these outside factors affect her in the now and in the future, and how that can affect the impact and the connection with the child, and their openness to the medical system. Because as we know, like Erica Garner, she was, I think, 4 months postpartum, and she passed away from a heart attack. And that death was preventable. So not even after they have given birth, they still need someone there to check on them, to make sure they're going to their appointments, to make sure that we are reducing stress. Like, these factors go beyond just beyond the birth. And I know we talk about a lot of the birthing experience, but even how in the United States, 6 weeks, the United States expects us to give birth, and after 6 weeks, we're just supposed to go back to the workforce.
People go back at 2 and 3.
Yeah, and so and even people are going back in 2 and 3, and so the body is going through all of these different hormone shifts. Your body is adjusting to having gone through this experience, and now you're expected to go back, and there is no choice. You have people who are married, have 2 sources of income, so they can stay home for. I know people who stay home for 6 months, 8 months, which they have the right and they should have, but then you have people who have to go back 6 weeks. That just, to me, is just unacceptable, because we're not valuing bodies, we're not valuing people's experiences, and we're not valuing the long-term effects that these experiences have on people.
Yeah, the U.S. is, I think, one of the few industrialized nations that doesn't have federally mandated maternity leave. So a school like SU is different because it's a private institution, but in most cases, if you have an employer and you have to come back to work in 6 weeks and you refuse, the employer is not, like, you're not protected by federal law, because the federal government hasn't mandated that across the board. But other countries, especially Scandinavia, has like the best statistics because of maternity and paternity leave, and because midwives are the ones that attend the majority of the births, right? Another tidbit, if you're interested in having a child or know someone, a midwifery model is more humane, because they're trained to look at birth physiologically, which means if you leave a person alone, the person's body will be able to know what to do to birth the child safely. It's when you start meddling and intervening that you start seeing the cascades of interventions that eventually lead to C-sections. I mean, New York has a very high C-section rates. We're at like 33. The World Health Organization suggests that the C-section rate remain at 15%, and we're at 30, 33, 34. So that, and we know because C-sections are profitable and they can be managed. They can be managed. I don't know, question?
I just wanted to say that Sequoia, the midwifery model of care, is something that Sequoia and I are truly passionate about, and it also is something that women in Syracuse don't really have access to at all. We have 3 main hospitals. One of the hospitals has a birthing center. It's baby friendly, but there are no VBACs. There's actually a hospital policy to say if you had a vaginal delivery, if you had a C-section, even of one time, you cannot have a vaginal delivery at that hospital. And so that is not evidence-based. It's actually disgustingly wrong. But there's a hospital that you can't birth in that way. This same hospital sees about at least half of the women of color here, the people of color here in Syracuse, and a lot of those people are refugee women. A lot of those refugee women have had 6, 7, and 8, and 9 babies vaginally at home, and they come here and they have a C-section. So that means that the hospital that's closest to them, they can't go to that hospital now to have their next child. A lot of those same people come down to a clinic that filters into that hospital, and this hospital also has a birthing center a birthing center that has a tub, and they're supposed to extend to you in a more non-interventionist way, but the doctors who deliver most of those women won't go to the birthing center. So then we have 2 other hospitals. One has a midwifery clinic. None of those midwives are people of color. They can't keep a midwife on staff. We have a hard time getting women in there. I mean, I could just keep going on and on. So I'm trying to get Sequoia to be a midwife as soon as possible.
And I think some people may be asking why advocate against C-sections? Who was born of C-section here? Who does not know their birth story? That's definitely key. I mean, I could be teaching a class about racism in the global world, and I'm like, please ask your parents your birth story, because holistically, there's claims that your birth, the way you were birthed, dictates a lot of the way you perceive life.
Yeah.
You know, and I'm a twin, and very traumatic. My mother was in bedridden for 3 months before we were born. A month before we were born, she was bedridden in the hospital. My sister was in an incubator. I was in the nursery. My mother was recovering. The 3 of us didn't see each other for like 4 days, right? And now I wonder why I have separation anxiety. Like, I cling on to my family, right? Because of that narrative that was created during my birth. But the reason why most birth workers advocate against C-sections is because they are oftentimes unnecessary. And a lot of women that we service, or people, they're like, oh, my doctor says that if I go over 40 weeks is like the cutoff a lot of times, and I'm gonna be induced to get a C-section. And they perceive it as like this thing where you just get rolled into a hospital OR, the baby is taken out of your abdomen, and then you it's an intensive abdomen surgery. And research has shown that there's links now, which a lot of allopathic doctors review or question, between childhood obesity and diabetes and C-sections, right? Because there's physiologically, when the baby squeezes down the birth canal, the baby's lungs also are squeezed, and the amniotic fluid is like squeezed out of the lungs. And there's also a lot of positive bacteria in the birth canal that the baby absorbs into the gut that increases the immune system.
Yeah.
So you look at the fact that they're saying this is the atrocious statistic, that this is going to be the first generation that's probably not going to outlive their parents. I'm like, what world are we living in when we're already predicting that our children are not going to live long lives, and that parents are going to, God forbid, but they're going to have to bury their children because of these diseases that could be prevented? Obviously, the access to nutritious food and air quality and water quality in this country are factors, but one of the factors that are often overlooked is how the child is birthed.
Right.
So this is why we advocate so strongly. And on top of that, for anybody that has had a C-section, I haven't, but I've seen a lot of women, the recovery process is intense.
Yeah.
They say 6 weeks.
Yeah.
It takes a woman 90 days for her to feel like a little bit stable enough. And a lot of times when a woman has a C-section, a person has a C-section, they can't really breastfeed because they're in a lot of pain. And breastfeeding has all these wonderful qualities that a lot of our people in our community are missing out of because of the factors that we're talking about. You know, and I think I appreciate this panel and this conversation because we are talking about all these dire statistics, but practitioners, birth workers, there's a few in the audience are here where we're doing this work on the ground on a consistent basis, right? This is not just theory. We don't just theorize it. We see it, and we also try to advocate, but doulas are very small in the large world of obstetrics care because there's a lot of, there's a contested relationship with a doula. Doulas are either loved or they're hated, right? It's like they're loved because the medical staff is like, okay, thank God I don't have to worry so much about this person because they have a trained professional that's going to be able to take care of them better than somebody that's alone. Or a lot of times doctors come in and they're like, there's this vibe that that they're competing with us. Why? Because if you come in and you're just like, oh, we're gonna rupture a membrane, or we're gonna induce Pitocin, we're gonna start Pitocin, we're gonna start this technical term, and I ask a question as a doula, right? The God complex, automatically the doctor is like, you're challenging me. In this chapter that I authored, I almost got kicked out of the first birth that I attended because of the simple fact, this was my cousin, that I was just asking questions, and I asked the residents to give the family, y'all, look how radical I was. I said, can the family please get time to talk, to consider the options that you're offering? They wanted to rupture the membrane, which means you insert something that looks like a plastic kneading needle, like what you knit with. They insert it into the cervix, and they pretty much pop the membrane like a balloon, and that induces labor quickly, but oftentimes the pain is intense, and then the person has to get Pitocin. So I wanted my cousin to understand what she was getting into. The doctor called me and chewed me out. And I don't stand back rarely, but I've learned how to not confront doctors, because the last thing a doula wants to do is to get kicked out of a room. Because then that person is left alone to advocate for themselves, and we know statistically what happens to any person, any race, any cultural background, but especially Black women, when we're left alone to birth in a hospital in the United States of America.
Yeah. And I just think, I mean, I don't know if it's because I'm a doula, but also just because of the research. I mean, there's so much good research now that shows how birth workers and doulas actually help to bring down infant and maternal mortality. I mean, it's overwhelming. And so even with our work in Healthy Start, like Sequoia and I and Miss Vicky, we could go on and on about the negative things, but we know that we're doing great work. You guys, these doulas are, it's a small group of women, but they are actually really and truly saving lives. I mean, Healthy Start is a small, is small in its outreach. They see about 900 women. And so the population in Syracuse is about 50% African American. And a lot of those women in Healthy Start I think it's 90%, isn't it? It's over half of the people enrolled in Healthy Start are African American women. Yeah. And so their rates for infant and maternal mortality, while in the larger population is 12, it is like 4 or 5. So it's on par with their white counterparts nationally. And so we are extending to them, and we also know that the doulas are part of the reason why those rates are so low, but that's only 900 women. So in this city. And so I think about that, but I also think about those other women, because we know that this is the solution. I think that sometimes in other movements, everybody's trying to figure out how can we solve this problem, how can we do it. But for infant and maternal mortality, for Black women, for Latino women, for refugee women who come over here and a year later their statistics look like African American women, this is the solution. Having a birth worker engage with them, hopefully before, during, and after they have their baby, that helps to reduce that statistic. So it feels bad, but it also feels so just phenomenal knowing that we know the solution. We have this agency as a communal response. Like, these women are from their community doing the work. I've only been here 6 years, and I met women who lived here all of their life, and they are now affecting their community. They are saving people, and it's amazing to watch.
So all that you guys have discussed, so my parents are from India. I was born and raised in New York City. So in an international point of view, how would you approach a problem like this? Because, at least in this country, I'm, regardless of my financial status, I'm privileged, if you compare me to my parents, because in this country, women they do get paid leave, not enough, but they do. In India, my dad told me when he was 10, he was, at a train station, and he saw a woman go in labor, and woman just went wrapped their stories around an area, and she gave birth at the train station. And train stations aren't really clean there. So from an international point of view, how would you approach that situation?
So that's an excellent question, because a village birth actually started in Uganda. with a Ugandan midwife. Her name is Florence Ochidi, and you will be surprised that how much those communities over there already know what to do. Yeah. I mean, so Florence was this amazing midwife. She's probably 70 some years old now, and she met my partner, and they just started having a conversation, and she described some of the same things that you're talking about. She talked about how women were so there's the major city, but then there are women who live in the villages, and they couldn't make it to the hospital, but you had all these traditional midwives who were excellent, but they needed updated understandings of how to birth. And so she was like, I need to train these women who are already working here in Uganda to have an understanding of evidence-based practice in 2006. And so it just became that's what it became. It became a partnership. And so I think that's happening all over. And I think that's part of the reason why we really started to think about doulas here in the United States, is because we connect with our sisters all over the world who actually are having the same exact experience, unfortunately.
Thank you for the question. Your question prompts me to think about, I always chuckle because Amnesty International has a report called Delhi Delivery, I think it was 2010, where they look at maternal mortality, just maternal statistics in general in a human rights framework. And there's always, I don't know if you all have heard it, but they categorize the statistics, how many babies die in the developed world and the developing world. And they'll be like, the United States is on par with Malawi.
Yeah.
I don't know, it's some country, in the continent of Africa, and it's like, how dare us? That's so offensive, right? Because first of all, it places the countries in the global south as if they're just not capable.
They're not adequate enough to handle their own situation.
They're not, and of course, infrastructure, yes, we're privileged to a certain extent. We have technologies. I'm not against allopathic medicine. I'm not against surgery. I'm not against C-section. I just think it's overused, right? But when you look at countries in the global south, like India, countries across Africa, countries in parts of Eastern Europe, Latin America, yes, there's a lot of factors that lead to mortality that could be avoided because of access to nutrition and access to potable water. Things like that we know are part of a long history of colonialism and imperialism, that it's not that these countries are just innately backwards or inferior. They are part of a long legacy where they've been structurally kept back from developing. But when you control for those factors, a lot of women in the global south know how to give birth naturally, and they're doing it in a very empowering way, right? I think that it's the idea that somehow because we're in the modernized world, we're better off. But if anything, the conundrum is that we are not, because the expectation is that we have all this money being pumped into healthcare, but we're still dying. Right, so I don't know what's worse, that you are affected because of the lack of infrastructure and access to clean water and resources in a country like India that leads women to die at certain rates, or that you're dying in a country that is so-called wealthy. I don't know what's more offensive, what's more of a slap in the face. So I would just ask you to continue, especially because you're still a student, and learning is never ending, to just continue to look at this as a global phenomenon, and understand that Black and brown women around the world, and women in general, we know how to give birth. We just know, because it's instinctively. It's when these medical professionals oftentimes play God, and they want to interfere, that the problem comes in. But I always chuckle when it's we're on par with Malawi. How embarrassing is that? It's not embarrassing. I mean,
I'm an old lady, so I grew up in Pike Road, Alabama. So I'm, God willing, will be 65 this year. And I grew up in the segregated South. Interesting in that there was this sisterhood.
Right.
And I think that's what probably was missing now, is the sisterhood.
Right.
The sisterhood, when my mother went into labor, somebody went and got mama somebody, and she came to the house. My brother and I were hiding behind the door, and I saw 2 chairs as stirrups in the bed, So And my grandmother and aunt said to my mom, you are not to leave this house for 6 weeks.
Yeah.
You know,
40
and they
days.
took care of her and us for 6
Yeah.
weeks. So that sisterhood we don't have, or we're losing,
Yeah.
and we have to fight for the sisterhood. We have to be there for each other. We have to encourage nursing. We have to realize that there's some things, probably a lot of things that we need to keep.
Yes.
And realize that this technology and all of this advancement, some of it is good and some of it isn't.
Yeah, I mean, thank you for sharing, because for Dominicans, we call the 6 weeks cuarentena, or it's quarantine. It's 40 days postpartum, where old school traditionally is like, you don't go outside, you don't wash your hair, you don't expose yourself to harsh chemicals, you don't cook. And I followed that. I understand that in today's world, it's a privilege to be able to say for 40 days, I'm not gonna do much because I have my mother, my twin sister, my cousins, my co-mothers, my baby has 2 co-mothers to come in and help. But there is a movement to start implementing that, like through policy, the same way that like ailing people or elders get like a home health aide to come into the home. There are people that are trying to advocate for a woman under public or private insurance to be able to have like not just a visiting nurse, but somebody to come in to cook and clean and tend to them, because statistically postpartum depression increases when a woman is isolated, right? And feels like she's alone, she has to breastfeed, doesn't know how to, and is left to fend for herself. So, I mean, I think it's a beautiful practice. Another thing that your comment made me think about, that again, it baffles students, that the way I frame feminism, which I've learned, especially here, is that, for me, feminism is not about equality, right? Right? The room, it's like, right? It's like, I do not want to be equal to a man. I don't. I want to be equal to another human being. I want to be treated like a human being, right? And sometimes it's not just that women or people don't have access to these services and these privileges postpartum or during labor. A lot of times I've had women after give birth and I'm just like, rest. No, I'm every woman. I can go out, I can do that. Because there's this internalized belief that there's a weakness in that. There's a weakness in taking those 6 weeks to repose and rest. And to me, it's so deep. It's about how we're even framing, a lot of feminism is oftentimes, or not, right? That it's such a contested phenomenon among Black women, and I understand, right? Is often a very important driving force in the birth justice movement, but it's so misunderstood oftentimes, because a lot of times women learn that, like, I want to have access to the rights and power of a man, but no, I just want to have the rights and access to live a life as a complete human being.
But we want equal pay for work of equal.
Right. Yes, right? Equal pay. Not the equal pay of a man, equal pay of a human being, for the getting paid the equal amount of wage for the work that we do.
I also wanted to comment on the idea of having multiple people in the room, and something that I discuss with my clients a lot of times is where are you delivering, and do you know their policy? Because even if you want to, so I have had a client who had about 7 people in the room. It was packed. And that's what she wanted. Like, she couldn't choose. She didn't decide. She couldn't come to a number. She's like, I just want my aunts. I want my cousins. I want these people here. And we were all there. You had to be quiet when she needed to have a contraction. And if you weren't quiet, you got to get kicked out. But another thing is, and then there's hospitals where there's only 2 people can be in the room. You can't switch out. And for me, I didn't know the policy for the latter hospital. And of course, they say it's for medical reasons and emergencies, and if there's too many people,
Check the mom.
things of that nature. But again, back to choice. So like even something as simple as, who do you want in the room? That's something that has to get discussed, because I've had clients who are like, what? My dad can't come back here? Like, I want my dad. But no, you've already selected your 2 support persons, and I couldn't even switch out. I was like, well, I'll even step out so that the dad could come in, and the other support person. And then this was a person who English was not their first language, so she spoke Spanish, and I'm having to interpret, and go back and forth with the nurse and saying, you know, that she's in this country. Her father is her only relative in this country, and because she selected me and her friend, he couldn't even, well, you know, I snuck him in, but we're not gonna talk about that. But the fact of the matter is, it was important for her father to be in there. It's important for the people who she was away from her family, and that one person that has seen her whole life, who he didn't want to be in there when she had the birth, but like being able to advocate for that and say, hey, this is important for her, and being able to recognize and help them understand that a lot of people don't have family, and had I not been there, had she not had someone interpreting for her, you know, she could have been very alone. So that's like, that's, for me, it's like the little things that impact the whole entire birthing experience, and it's so important to be able to ask these questions so that they aren't blindsided when they're in labor and they're like, oh no, you know, my loved one. And then initially there are some hospitals who have policies that if your physician isn't on call, they cannot come and deliver your baby. And that's a conversation I have with my clients. Do you know what the hospital policy is? Because I had a client who went in labor, she didn't know that. And so this whole 9 months, she has built a relationship with her midwife to only be told by a physician, oh no, you're not having a VBAC, you're having a C-section. And I was like, oh no. You know, these are the type of things that if you don't know, it can really just change the outcome of the birth.
I mean, as you were speaking, a lot of people don't know that by law, you can no longer record a baby being born in a hospital room here, right? And not even by law. It's not like mandated by law. It's ACOG, the American College of Obstetrics and Gynecology. Why do y'all think there's been a ban on recordings? Because you won't catch them in the act? Negligence, right? Liability. A lot of the things that we've been talking about after the structural racism that is the foundation of this country, and sexism and all these other isms, that liability is one of the driving forces of a lot of these dire statistics that we're talking about. Doctors are afraid of getting sued, right? So they'll do anything in their power to, I mean, there's even, you know, a lot of literature shows that doctors, OBs, would rather do a C-section than allow the woman to birth naturally, vaginally, if there's like a hiccup in the heart rate or the blood pressure increases or decreases. Because the idea is that if they're brought in front of a judge, they can say, well, C-sections have a protocol from A to Z, and I followed it, whereas vaginal birth is it's more spontaneous, and there really isn't like a protocol for it. So there's more loopholes for the doctor to really be held accountable. So a lot of doctors will rush to have a C-section, because also there's this idea that if the woman or the person gets a C-section, the doctor comes off as like, this shows that I tried my very best, right? So at the bottom line is that they're afraid of getting sued. So think about how that is like what's driving a lot of doctors during med school, during residency, when they become doctors, where yes, it should be about the care of the person, but the second factor is that I don't want to get my ass sued.
Hi, thank you so much for coming tonight. I've lived here in Syracuse for more than 10 years now, and it's amazing to hear about this organization for the first time. And I'm doing my master's here at SU, and my project is on miscarriage and stillbirth and pregnancy loss. And I was curious, just as we've kind of run the gamut of everything from essentially conception to pre-labor and then labor and then postpartum, can you talk a little bit maybe about the silence and the stigma that surrounds everything from, you know, conception all the way through to having given birth or lost a baby, and just how you all work with your clients through that?
Right. For me, so I've had someone who had a miscarriage, and I think a lot of times when people miscarry, they're thinking about what could they have done differently. And so there's like a lot of self-blame. There's other people blaming them. Well, what did you do? You didn't do something right. And what we know is that there are certain miscarriages. They're spontaneous. There's a myriad of reasons why. And I think for me, it's contextualizing those experiences and helping them to realize that it wasn't your fault. you know, and being able to also help them go through if there were liabilities that happened. So I know someone who they found out they were pregnant and they wanted to have an appointment. They wanted to have an appointment because they weren't feeling good and they just wanted to make sure everything was okay. But they were told that they were booking out all the way into her second trimester. So you're telling me that I have to be pregnant 3 months and I can't have a prenatal appointment until my second trimester. And so then, you know, she finally gets the appointment, not seen because they're running late, right? So you're taking time, energy, money to taking off on work, and then to have a miscarriage, and then to say, okay, well, I did everything that I could. I didn't feel well. I tried to go to the doctor. I went to the ER. They kept telling me nothing was wrong. So for me, it's being able to contextualize what that experience is, and also giving them space. For me, language, you know, oh, well, you know, everything happens for that type of stuff doesn't comfort a person. Everything happens for a reason. So just being able to say, you know, I'm here for you. You know, what can I do for you? Instead of assuming that you have all the answers to helping that person through the situation.
I think one of the things that we really try to focus on in our training is redefining what a miscarriage is. I think a lot of people in the community, and just women too, also, they're surprised about how sad they are. You know, you lost a baby, and I think if you never had that experience before, you don't know how deeply it can go. Mm-hmm. And so supporting someone who has lost a baby, it teaches you, because you see the stages that they go through. And then you also see how other people react to them. They have to go back to work. You know, they're not expected to be sad. You know, it's supposed to be something that's kept, you know, very deep. And so really teaching people how to gather around those moments. I mean, it's trauma. It's more trauma. So, and just like she was talking about birth stories, we take that miscarriage to the next baby. Mm-hmm. And women who become pregnant again, especially very soon after, there's all this fear around their baby and carrying and having that baby. And am I going to make it to 40 weeks? And especially if you had a stillborn baby, depending on when that is, if you're 9 months and you have to go deliver your baby, that is something just unimaginable. And I think that could be a lot for this space, but I think that really thinking about how we gather around those type of situations is really that's the solution. Because at this point, we're not going to get support. You know, we can't get our doctor or the nurse to change their extension. We have to figure out how communities change. And I really love that piece about how you talk about the sister collective, because, you know, when I think about doula work, that's exactly what it is. That energy vibrates throughout. Yeah. It's a vibration, and we need more of that collective presence around any experience around birth, and also thinking about how we raise birthing people in general. My daughter just went to that women's empowerment this weekend, and I didn't know she was going to be there, but Asada came home and she was just like, oh my goodness, I mean, it takes a lot to move this child. And so she, you know, she's seen like she got a big family, you know, so she texts me all day. I'm like, don't you need to be engaged? She's like, I am engaged. So I think, you know, these type of models where we start at, you know, whenever that baby is ready to talk, we start talking about birthing justice. We start talking about healing powers, and, you know, reproductive energies that people are facing. Like my daughter's 17, and she has all of these feelings around, you know, who she likes and how that feels and what she's going to do with that physically and otherwise, and really engaging her so that she feels powerful in her own agency. I think that's doula work. So I think that is how we start to heal some of the trauma that I know she's facing as a child, and that she will face as an adult also too.
So really quick, and I'll address the question, but I mean, Haley, thank you for I know that it's DK and it's a collective, but being in your shoes at one point, I know how much you've worked to make this happen, right? But also, I think, Haley and I are connected. I think maybe it's a past life thing. Just a tidbit. So I'm on the board of the Image Initiative, which was a beautiful vision of Nicole Jones, who was at the time a master's student here. I think she was doing her MBA, and she had to create like a project, and she started, I want to gather 100 young women of color in high school in Syracuse. This was in 2004, right? 14 years later, the conference still happens in March every week. I mean, Marissa's here. She's on the board also, right? So it's tireless work. I mean, we were in this wrap-up meeting for like 2 hours, and we're talking about, we're going to meet in like 2 weeks to start talking about next year's conference. Anyway, so I'm at the conference, I'm in the bathroom, and her daughter's in the bathroom, right? So I'm like, hey, how are you? I'm like, what's your name? And she's like, Asada. And I'm like, oh, are you named after Asada Shakur? She's like, yeah. I go into the bathroom, so funny, right? And I'm like, wow, I'm really old. I'm getting old because someone's named after Asada, right? So her and I are talking, and she's like, oh, my daughter's name is Asada. Like, I mean, come to find out, I met her daughter, like, happenstance in the bathroom.
Yes.
Just how, I don't know, there's synergy, right? But about the miscarriages, I mean, I know 2 people very near and dear to me who've had stillbirths. And I've only been like a 7th or 8th party experiencing that. And I just know how, especially a stillbirth in particular, how exceptionally traumatizing it can be. I teach I think it's an interesting class, a gender studies class at City College, where I take the students through a trajectory where we make the connections between like the witch hunts in 13th, 14th, 15th century Western Europe and birth injustice today. So the connection is that, of course, empowered women have always been demonized and punished within a capitalist context. And in a sense, that legacy continues today with how women are treated during birth. But I think with miscarriages, I see a connection where women within capitalism have been conditioned to believe that our role is to produce babies, right? As a Latina in particular, being Dominican, where the colonial trauma is intense, because that's where Columbus and his lackeys developed, the framework for, the mind and body control that we experience today. There's a lot of pressure in, you're not a woman until you give birth. So I have an identical twin sister, and the day that I told my mother that I was pregnant, she was ecstatic. And 12 seconds later, she tells my twin, how about you? When are you going to give birth? I gave birth, and the day I gave birth, my mother, she's a sweet little old black Dominican woman. She's 74. She comes to me, and she's like, ahora tú eres una mujer. She's like, now you're a woman, right? And I'm 33 at the time. So I think that I get the sense that with miscarriages, a lot of people internalize this idea that they didn't fulfill that duty that is the bottom line for a woman, right? I'm about to be 37, and a lot of the clients that are coming into my realm, they come to me with a lot of shame. Like, I've been trying to have a baby for 4 years and I can't. I may be sterile. I don't know what's wrong with me, right? It's this idea that if we're not producing babies, we're not productive.
Right.
And of course, my sister and I now have this platform. It's called Brujas of Brooklyn, which is of Brooklyn. And our platform is based on yoni power or womb power. And we try to create workshops where we expose people, women in particular, to the reality that our wombs are not just to create children. Women, we create visions and ideas, right? I birthed my dissertation through my womb. That's how I see it. Right, so I think it's also about reframing the narrative about our value as women, that it doesn't just lie in whether we have children or not.
Excellent.
I wanted to ask if you have, I wanted to ask if this movement that you are part of now, promoting, the significance of doula work in birthing care, in healthcare in America. If you look at other countries, you talked about it a bit, Griselda, in global north countries, that this is not the practice that the United States compares with so many countries in the global south. But I mean, countries like right next door in Canada, where this is acceptable. And if you don't have a doula or a midwife, you can bring the whole family into the, labor and delivery. And that doctors don't necessarily have the same reaction. I must say that C-sections are on the rise because oftentimes it's for the convenience of the doctor, right? He has to get on the boat and go wherever he was going in the summer, and so he forces this. That happens there as well. But the practice of birth is, I would say, as a former phlebotomist who worked a lot in labor and delivery rooms, that this is not half as traumatizing as it is in this country. So if part of what you're looking at, I want to find out, is how, I don't want to say something as amorphous as capitalism, it manifests itself in this country that commodifies birth and labor.
Yeah, I mean, I'm just tirelessly researching and reading this phenomenon for years. Scandinavia is always where birth workers are led to look because they have amazing statistics, right? Canada is often included, but not quite, but that's especially considering we're so close. But I think that's the conundrum. Like, how do we live in such a industrialized, modern, technologically advanced country like the US, and we have such dire statistics? I think we, as doulas, we're doing the work, but we don't have the power as of yet to enact policy that's necessary. I mean, something as simple as, still to this day, even though the American College of Obstetrics and Gynecology has determined that a person should be able to eat during labor, a person still is not allowed to eat for 12 to 36 hours. They just are allowed to eat ice chips. And there's research, right? But there's a lag between when the research is published and when it's put into practice. But I think we may have to look at our neighbors up north to see what they may be doing or not doing, because we're still struggling. But we're here, right? I don't want to stay in this. We're here to kind of with testimonies that.
Well, that's what I'm saying, that this to me feels like a movement that you're part of. So I was asking for comparisons with that.
Well, I
movement.
think,
Okay.
I think too that like what we're doing is we're formalizing traditional practices. I mean, this is what we have to do because unfortunately, it is capitalism, it is industrialization that in the beginning of the 19th century really pushed birth into the hospital and really put it into this framework of medicine that if you are having a baby, it's almost treated like you have a disease. So the same protocol that they're using for childbirth in the hospital, I worked in the hospital, is medically nuanced in the way that if you go to the hospital for open heart surgery. So like the language around nursing care is medicalized. We are trained to be acute responders. So we're looking for the problem right away. So I think that's very different. Like childbirth is its own entity. It's not a disease. Our bodies are not diseased. And so because we are not responding to the normal physiological process of the experience, we have these outcomes that aren't good. And I think that, a lot of times around globally, just reading, and I haven't traveled a whole bunch of different places, but I think that communities, people in birth, automatically form doula collectives. They're not called doula collectives, but that's the response, to mob up around that person who's having a baby. And it's only when those environmental factors come into play, like lack of clean water, those are when you start to have poor outcomes. Or when people think that they should travel, or when they don't have someone and they're traveling, 12 miles walking to get to a hospital somewhere else. So I actually think it really is industrialization and capitalism and all of those isms that have caused these outcomes without thinking about how childbirth is not a medical event most of the time, and it hasn't been since the beginning of time.
I mean, something else that came to mind is that in the U.S., there's only one national collective that's recognized, which is DONA, Doulas of North America. So there's not like a formal umbrella for birth workers to organize, but then DONA is, to me, a very white space, right? So I didn't train under DONA because I didn't see myself in DONA. So I don't think that as of yet, doulas, we have pockets of organized movements, and it's getting a little tighter because of social media. You know, I met this doula collective in a decolonizing birth conference back in October. So we're starting to bridge a lot of these gaps, but the only formally recognized body of doulas is this collective that's run and administered by white women. So we, black women, I mean, sister song, right? But we don't, there's not like a formal collective nationally yet.
Yeah, it isn't, and I think that the kind of birth work that these community-based organizations are doing and training people to do is something very different. So Donna kind of sprang out of that anime Gaskins, you know, the comfort measures, and those are all medically evidence-based needs too, like that need to have a non-medical support person in birth actually improves outcomes for white women. It does. But because of racism and all of those things and the way that poverty and racism and how we exist in this country, we need something else. We need a different kind of model. So a lot of community-based organizations are trying to come together, but it's really hard. DONA is funded. I mean, we're not funded. We try to connect with the health department, but that really limits what we can do too.
Yeah.
So we are extending to people who have. There are a lot of people of color who we can serve, who can afford this service, but 99% of those people that we are extending to in Syracuse, they can't afford it. So we can't charge $3,000 like a donor person would. We can't charge that for a birth. We can't charge anything. I had people cook for me before. So I mean, we're talking about a whole nother set of circumstances that we're responding to, but also don't really allow us to formalize in that way that DONA does. And sometimes people think that we don't want to, because the other thing about connecting with institutions in that way is that they take it from the community. You know, I mean, Syracuse is full of you know, infant and maternal mortality agencies, all mostly, sorry, but they're led by white women who don't live in the city. The public health nurses, there's like 17 of them. None of them are people of color. And so these are the people who are responding to women pre and postpartum in Syracuse, and they have no idea what they're walking into every single time. And so while they're doing great work, I'm sure, but they aren't connecting at the most fundamental level, which is really where we need. That's what we need. So, yeah. Mm-hmm. So this is a national thing. There's Ancient Song, there's Village Birth, there's Mama Toto, there's Claudia Booker, there's Shafia Monroe, there's all these other people that are really starting to see how communities need to be in charge of birth again. And we really need to take it back in that way. And part of it sometimes means, you know, we have to do it without funding, and we have to do it without partnering up with the institutions.
I mean, oftentimes we're asked whether we want doulas to be covered by health insurance, because as of now, doulas are not covered. There are programs that they'll reimburse the client, or Medicaid in New York often offers women the option of having a doula, and then we get like $500 like 7 months later, right? But back to the institutional domination, a lot of doulas of color in New York City, we're wary because then the certifications come into play.
Yep.
And you can't participate if you don't have these trainings, and the trainings
You have to
cost
have
$400.
insurance.
You have to have insurance. So we're almost like maroon-ish as
Yeah.
doulas, and there's a part of me that still appreciates that, because we could sneak people into the room. We could sneak food into the room for the person to eat. There's a lot that goes undetected because of the fact that this practice is not formalized. So it's like bittersweet, because of course, ideally we would want insurance companies to pay us so that the person or the family wouldn't have to pay out of pocket. But then we're like, what will that look like if the state intervenes and starts dictating what we can't and can do?
And for me, it's about I personally stepped away from working with an institution-based organization because I can't be out here fighting for everyone else's autonomy and then when it comes to me making choices about my body, whether or not, I want something like the flu shot or not. Like, when these ethical decisions for myself, if I'm not making those decisions for myself, for me, I'm doing myself a disservice in my community. And so for me, I think overwhelming majority of my births have been unpaid, because I recognize that the value is in being able to do the work, and somehow it comes back to me. And so I think that one way that communities can do is, if there are doulas in the community, being able to donate, being able to recognize that. For me, I would love to do doula work full time, but it's not sustainable. I can't pay my bills, and I also don't feel comfortable charging clients $1,000. For me, that's unethical in and of itself, unless you can afford it. Anyway, but I think that there's a lot. For me, I'm a principled person, and so a lot of decisions that I make as a doula are principled. And if I can't make those decisions and have that consciousness for myself, then I feel like I'm doing a disservice to my clients as well. And so a lot of the times we talk, and then on top of that, when you have these organizations say, well, if you don't abide by this policy, well, you can do the work for free. And it's like, so you're already asking a black woman who's underpaid and overworked to do work for free, that I have no problem doing it, but for you, an institution who has funds, to say, well, you should just do it for free. I'm like, okay, well, that's what I'm gonna do, but it's problematic that you, a source of income, aren't willing to respect people's decisions and agency, and also respect the value and work that they have and that they are doing. So I know that I'm saving lives, and these institutions that claim they want to save lives does not even want to reward that labor. It's problematic in of itself. So for me, and then when you're trying to live, like, at the end of the day, this system that we live in is based on survival, and it's not really based on fulfillment. And I think that's just a much larger conversation that we don't need to have today.
I think that is a good place to draw. Even though I don't know about anybody else in the room, but I'm so not ready for this conversation to end. I just want to thank you for. I've done a lot of these conversations. I've been really blessed to do the work that I do, and I must say that this conversation feels particularly powerful, incredibly necessary, really expansive. Thank you so much.
Thank you.
And I also want to feed you, so it is a good place for us to stop. We've gone an hour and a half. Again, thank you, and for everybody in the room, there is food in the back too.
Thank you.
So please eat.
Thank you. Thank you.